Hello everyone and welcome to our discussion of the INI CET recall based questions of pathology 2020. I already told you my own assumption and the feelings of this paper was very conceptual, was multiple choice, actually made it a bit tough, but I'm very sure my students have done very good. And actually this question paper is loaded with hematology. One thing you must understand is as the time is growing up, you must be able to understand the concept behind a disease rather than just knowing the most common and the most frequently asked statements from the topic. Now, here I am discussing the INI CET recall based questions. I'm telling you there's a whopping number of 28 questions from pathology, and I'm very happy to tell you most of the questions are directly from my teaching in the regular batches. So, here I'm starting with the first question, which says a 20-year-old female, she has a easy fertility and pallor, which tells it's a type of anemia. And what is the finding shown here? That she has some, hyperpigmented knuckles, and basically she also has a white nails. So hyperpigmented knuckles and a white nail, along with a feature of anemia, doesn't actually go into aplastic anemia, which will definitely show a huge amount of pancytopenia and infection history. Can't be this. It can't be iron deficiency anemia because it will show you the spooning of the nail, which is definitely not seen here. And hypoalbuminemia will have edema. So definitely you can exclude and come to the answer of B12, which shows there's history giving as hyperpigmented knuckles and the white nails. The answer is B12 deficiency. Well, this is how I actually start my class as a first day of pathology, the first few minutes who attend my class. So I tell you, exact same image came in this year's INI. Remember, with this cell, this first one is actually it's a neutrophil. As you see here, it's a neutrophil. Okay, it's a neutrophil with a three lobes. Okay, three lobes. This one is actually a eosinophil. Sorry, it's a eosinophil. This cell here, it's a neutrophil. Okay, it's a neutrophil. This is a lymphocyte. Okay, and this one is a monocyte. Guys, all these cells are here RBCs, while this cell here is a platelet. This cell here is a platelet. And you were asked to identify most of the cells, which I'm very sure you might have been able to. Question 3. The most common retroperitoneal tumor is, guys, remember, the most common of them is liposarcoma. Remember, neurofibroma is a tumor of the nerves. So, neurofibroma will actually be in the posterior mediastinum, but is not the most common. In fact, neuroma might be the most common posterior tumor, but definitely not neurofibroma. Rhabdomyosarcoma is the most common soft tissue tumor in children, but definitely not the retroperitoneal tumor. And cerebral sarcoma is definitely not retroperitoneal. It usually occurs in the joints. So even if you don't know anything about it, you can definitely come to the right answer, which is actually liposarcoma, which is the most common soft tissue sarcoma in children or adults, and is also seen as the most common retroperitoneal tumor. A good question. About telomerase, all are true except. Actually, this question is asking you about telomerase. And what is telomerase, guys? Telomerase is nothing but a enzyme, right? It's an enzyme. And the enzyme is what? It's actually a reverse transcriptase. It's a RNA polymerase enzyme, which will help to make the DNA from an RNA primer. So what happens that it actually helps, as you all know, to maintain the chromosomal length. That is how it actually makes what? Telomere. And telomere, you all remember, will be at the ends of the chromosome. So this would be the telomere. This is the telomere T, and this is the telomere T. And the telomere will help. The telomere will actually help to not allow the chromosome to get shortened. And remember, how does the telomerase act? I'll just show you a small image. Suppose this is the end of the chromosome. As you all know, it's AT and CG rich area. Like you see the AT area and the CG rich areas. Now, at the end, the telomerase enzyme binds to it. The telomerase enzyme, there's a telomerase enzyme which binds to it. Okay, and telomerase, it has a telomeric RNA. Okay, it has telomeric RNA itself. Okay, but the problem is, see, this is how the normal chromosome is. So if the chromosome is like this, the ends are just increasing. Like this is overhanging. Look, this is overhanging ends. This overhanging ends is often recognized by our own body as DNA breaks. So our body will always try to repair it. But actually, this is not to repair. It is actually to maintain the chromosome length. And therefore, the telomerase has to prevent itself from DNA repair. Rather than causing DNA repair, it should not allow the DNA repair to happen. So this is a telomerase. See, this telomerase, it brings upon telomeric RNA. This telomeric RNA will make the reverse transcriptive activities. It will make the entire DNA here, DNA, and then what will happen? There is extension of the chain here by the primase and the polymerase as we did in genetics, and then the short segment here is removed. Which is removed? The small RNA primer. Remember this RNA primer, which was actually a part of the telomerase? It is then removed, and then the whole thing starts extending. So what I want to tell you here is this whole thing actually has a reverse transcriptase enzyme. Yes. High fidelity of DNA synthesis. Yes. Why? Because they have the DNA polymerase enzyme. They have a DNA polymerase enzyme. Only in eukaryotes? Definitely yes, because prokaryotes do not have the chromosome, they have the nucleoid. And definitely they are not involved in DNA repair. Instead, they prevent the ends of the chromosome from getting repaired by the DNA repair enzymes. Okay, so answer is D. Answer is D. Next question. Staining of the lipid is best with. Now, I hope you all have seen this question as repeating many a times. The fresh tissue is always stained by actually a lipid is frozen section. It's frozen section. Okay. So remember the paraffin sections they have, and the formalin fixed sections, they all have what? They have what? They have alcohol, and the lipid will always be soluble with alcohol, hence can't be used, and therefore the answer is frozen section. Okay. Wrong statement about NLPHL. So what is NLPHL, guys? It is nodular lymphocyte predominant Hodgkin lymphoma. Is classical or non-classical? Remember, it is non-classical Hodgkin lymphoma. So when I say non-classical, you already know the few facts. It should be 20 positive. Yes. 15-30 negative. Yes. They should be Epstein-Barr virus negative. Yes. And I told you this has the best prognosis in comparison to any Hodgkin's lymphoma. So correct answer is D. Remember, they show popcorn cells as a type of the Reed-Sternberg cell, and these all things have been discussed very clearly in our regular classes. Okay. Seventh, a patient with weight gain, lassitude. So weight gain and lassitude means fatigability. So he is gaining weight, he has a small amount of fatigability and shows increased TSH, guys, low T4. That means, see, there's a low T4 and there's a high TSH. Why will this happen? Obviously because of feedback regulation. But now you must understand, a high TSH and a low T4, this will occur only if the patient has a problem in the thyroid gland itself. That means it can be Hashimoto thyroiditis, which will actually show you decrease in the T3, decrease in T4, and that causes increase in TSH. But a Graves' disease will show you increase in the T3, increase in T4, and hence can't be the answer. Pituitary adenoma will have an increase in the TSH, and hence it can't be the answer. Hypoparathyroid has nothing to do with the thyroid. It basically is just a decrease in the calcium, which is often seen here. And so clearly the answer is Hashimoto. There is no other possibility in the given question. Okay. Next, a 14-month-old patient with repeated blood transfusion history. Okay. And hemoglobin is very low, 6.3. And he has been given transfusions in 6 months. He has a repeated blood transfusion in the last 6 months. See, now, if you look at this peripheral smear, this is an NRBC. It's an NRBC. And even though this image is not very clear, but it was showing basically polychromasia. That means a slightly, darker color RBCs. And was showing to you an isopoikilocytosis. Guys, this patient, it also had a history of maxillary protrusion. Okay, there's also a history given was of maxillary protrusion. So if you asking me, sir, what is the likely diagnosis, I'll say it is towards thalassemia. Okay, now if you tell me, sir, if it is thalassemia, the answer should be a parental HPLC. What is parental HPLC, guys? See, a parental HPLC is a condition in which you see a child has a HPLC giving a HbF, but HbF in a child can be due to an increase of HbF, which is physiological, because as you all know, HbF starts reducing just after the birth, but is not exactly normal even up to 1 year of life. So often you confirm them by looking for the parental HPLC and looking whether the parents have a hemoglobinopathies, that is thalassemia or not. Now, but the problem is you have one more good, very, very good, choice, that is globin gene sequencing. Now, globin gene sequencing is the most diagnostic test, and you cannot beat this one even if you go with parental HPLC. So, guys, for this, a better answer is B compared to A. There's no doubt about it. Please understand, if the option would not have been B, I would have taken A. But with B given in the option, I cannot take A. Ferritin has nothing to do with this because ferritin is just a non-specific test, and bone marrow aspiration is never done as a diagnosis in a case of hemolytic anemias. Okay. Now, absence of marked structure will present with all of the following except. Okay. Now, see guys, what is marked here? It shows you basically a type of parietal or auxentic cells. Okay. Auxentic cells or a type of the parietal cells. Okay. Auxentic and parietal cells. And remember, among the given options, it is given which of them will be shown except. So, which of these four disease can be there with an absent of parietal cell? That means in simple words, it is asking you among these four, which of them will have, yes, increased parietal cells. And you all know it is definitely a case of Zollinger-Ellison syndrome, because this will show you a increase in parietal and not an absence of parietal cells. Well, all others will show you a decrease in the parietal cells, that is B12 deficiency, a pernicious anemia, and Carcinoid syndrome also shows you basically a decrease in the parietal cells, but Zollinger-Ellison syndrome will show you an increase in the parietal cells, and hence is the answer. Okay. 10th. Now this case about a patient having a translocation 1114, it shows what? It shows mantle zone lymphoma. Okay, it shows mantle zone lymphoma. So if you remember, mantle zone lymphoma have few findings that you must all remember. They have 1114 and 11. If you hold, remember, the 11 is nothing but cyclin D. This is a chromosome number 11. So this is definitely true. Okay, 200 has nothing to do with this one, so can't be the answer. SOX11, yes, it's a repeat question, so definitely A and C, both of them should be the answer. CD10, it's actually a marker of germinal center. So any germinal center lymphoma, including ALL, will be positive for CD10. Others are usually not positive for CD10, and hence the answer is A and C. The diagnosis is mantle zone lymphoma. Okay, a patient who is not responding to treatment. Physician suspects suboptimal drug dose, and the simple question is asking you what all things can be used to do a drug monitoring analysis. See, for drug monitoring, basically we use HPLC always. Okay, HPLC. But yes, please understand that even a flow cytometry, NMR, or a spectrophotometry is usually can be done. But if you want to choose one of them, it is spectrophotometry and HPLC only. So these two are the best options. NMR is definitely not one of them, and flow cytometry is not actually used for drug analysis. It is used for looking for some markers on the leftover cells. So I will go with B and D, which can be used to look for any rosacea analysis. Okay, spectrophotometry is just a light based test in which you pass the light through through any substance, and the amount of light passing through tells you the concentration of that substance in the given solvent. Okay, so you can use both B and D. Well, this is a typical match the following, and I have already matched it. See, silicosis, this shows you basically an X-ray finding, shows you a crazy pavement appearance in the X-ray and the CT scan. Mesothelioma shows the malignant pleural effusion without a shift in the mesothelium, and hence called as malignant mesothelioma. Kaplan syndrome, it was shown first in the co-worker pneumoconiosis, and as well as you all know, involves the basal lobe. Okay, it's a straight away question because you already know about the B and D. You can very well match the other given options. Methylation. What exactly is methylation? I hope you remember, guys, there is something called as non-histone proteins, which helps in the extra packing of the chromosomes. Okay, so what happens? The methylation process is actually responsible for, see, gene alteration. Yes, because it causes gene silencing. It actually causes gene silencing. It causes chromatin remodification. And RNA splicing is also seen to be having some role with methylation, but definitely it doesn't have any role in the base excision repair. Remember, for base excision repair, there are some polymerase 3 enzymes which is actually very helpful, but definitely not methylation. Okay, the answer is D. MPGN. Well, membranoproliferative glomerulonephritis, I hope you remember the MPGN type 1, MPGN type 2, and remember the MPGN has some basic etiologies. If you remember, HIV, SLE, especially it shows the MPGN type 2, and the hepatitis B is also one of them. CLL can also show you MPGN. So answer is all of them. So option with A, B, C and D is the right answer for MPGN. Remember the finding of MPGN type 1 and type 2. The type 1 shows tram track appearance. The type 2 shows dense deposit disease. Okay. Reticular fibers. What are these fibers? Basically guys, any tissue has some collagen fibers like this. See, all these collagen fibers here now stained with this silver stain is all the collagen fibers giving you reticular staining. But the problem in the question is reticular fibers are seen in all of them. Remember, any tissue which basically is a lymphoreticular tissue, that means any tissue which has lymphocytes and has a, I will say, lymphatic channels in it will definitely have reticular tissues. All of them will have it. But it makes a structural framework of all except, that means not is in the question. I will go with the thymus, because thymus, even though has reticular fibers, doesn't have a framework made up of the reticular fibers. So the answer is definitely A. Remember, it is seen in bone marrow, it is seen in spleen, it is seen in lymph node, can also be seen in liver. Liver also has reticular fibers, because the question is asking you structural framework. Okay. Adenocarcinoma in mets in the liver was seen, and given you CK20 is positive and CK7 is negative. So what do you think is the answer? Well, this question can be solved by a simple explanation of this table. See, if patient has 7 positive, 20 positive, it could be bladder, pancreas and ovary. 7 positive, 20 negative, that means 7 is positive, breast, ovary, endometrium, thyroid and lung. If it is 20 positive, colorectal carcinoma, this is how they picked the question, was the question. And both of them negative is seen many tumors, like can be HCC, prostate, kidney and squamous and neuroendocrine tumors. CK stands for cytokeratin. Try to remember this table, especially this one and this one. Okay. Which clotting factor deficiency will not affect clotting? Remember this unique fact that factor 12 deficiency, this deficiency leads to thrombosis. In fact, the role in clotting is very limited, has a very limited role in clotting. And therefore, if you remember, the 12 deficiency neither causes increase in the APT nor causes increase in the PT and APT, either of them. So the answer is factor 12. Remember, factor 12 called Hagman factor has a very limited role in the activation of clotting. I hope you remember Hagman factor is basically active more in the in vitro activation of clotting, not in vivo activation of clotting. Okay. Okay, this one. So what is the diagnosis here? This image simply shows you what? Yes, it's a case of hyper segmented neutrophil. Well guys, remember one thing, the hyper segmented neutrophil is seen in B12 deficiency, that is the megaloblastic anemia. Definitely not seen in iron deficiency anemia, and definitely not seen in the hereditary spherocytosis. MDS, well, this can show you hyper segmented neutrophils. So I'm not sure exactly this question was to choose many of the options, but if it was, the answer would be A if it is one choice, and but if the question is giving you multiple choices, then it would be A and D, both of them. Yes, so it's a bit tricky question, but this is all a bit a factual question if you can remember it. Okay, rapid assessment of the entire coagulation pathway in emergency. I know that most of you would have marked something else, but I'm telling you guys, just look at the options. PT, it is used for extrinsic pathway and the common pathway. You're not measuring intrinsic pathway. ABT, intrinsic pathway, common pathway. You're not measuring the extrinsic pathway here. CT is not done at all nowadays. Not done at all nowadays. If you go with simply excluding the option, you get with the answer. thromboelastography. What is it? See, a thromboelastography is basically a machine in which you allow a test to perform in the way that you put the blood. It is an automated instrument. You put the blood, and that instrument, it activates the clotting pathway. Okay, so the first of all, the clot starts forming. It measures what is the amount of time it is taking to make the clot, and then after the clot has formed, it will then lyse the clot. So the different time interval is measured by the tag. See the first one. So the till the time, see, if this is the start of the clotting factor and this is where the clot starts forming. So this time is called as reaction time. The reaction time measures the clotting factor deficiency. It can look for the hypercoagulable states or the fresh frozen plasma given to the patient. Okay. Now see, at this point, the clot is starting to form. So this is where the clot has formed, this and this. Okay. Now see, the clot formation time is again measured, which can tell you the amount of fibrinogen. Well, the maximum amount of clot formed is measured by the maximum amplitude, which tells you about the platelet number. It tells you about the combined action of the platelets and the fibrin both. And then it starts lysing the entire clot. So lysis is seen, and it then looks for how important, how active the lytic pathways are in the patient. So what you can say is entire clotting thing is seen by this machine called as TEG. TEG is thromboelastography. It's a new thing, but once the question has come, you must know about this. But I can tell you guys, you could have answered this just by excluding the options, as it can't be PT or APT. CT is not done at all nowadays. Okay, now this became a bit controversial because many students were giving a different thought on this question. Most common cause of lung injury in COVID-19. So if it's asking you most common cause of lung injury, it definitely is DAD, because this is causing ARDS. But if the question is most common lung finding in a case of COVID-19, it would be endothelial injury. Please understand, endothelial injury is the one which starts it and is the most common finding. But if you are saying most common cause, but the cause is definitely ARDS, which is actually diffuse alveolar damage. It is therefore diffuse alveolar damage. Okay. 21. Well, the question is asking you Peutz-Jeghers syndrome. I told you a simple, a table in which I told you the juvenile polyposis syndrome and the Peutz-Jeghers syndrome. The Peutz-Jeghers syndrome, it shows what? It is an autosomal dominant. It is autosomal dominant disease in which you see multiple GI polyps. There is a STK11 mutation. Unlike the SMAD4 seen in juvenile polyposis syndrome, it is arborizing pattern, which is a histopathology. And remember, it shows mucocutaneous oral pigmentation and not this, because this finding is seen in what? It is seen in the FAP, familial adenomatous polyposis. Remember, this Peutz-Jeghers shows what? It shows mucocutaneous hyperpigmentation. Mucocutaneous hyperpigmentation, and does not show FAP. Does not show FAP. Okay. 22. The bone marrow is showing you dry tap, least likely causes. What is dry tap? Dry tap is a condition where the bone marrow aspiration shows no aspiration. You can't aspirate anything out when you do a bone marrow aspiration. It is seen often when a case of bone marrow is getting fibrotic. So which of them will show you fibrotic bone marrow? Definitely hairy cell leukemia. Definitely not follicular lymphoma. AML M7 will definitely show you a bone marrow fibrosis, and MDS can always show you a dry tap because the cells are quite adhered and may not come out easily. So the answer is B, which will show you not decreased but increased cellularity in the bone marrow. The answer is follicular lymphoma. JAK2 mutation is seen in. Remember guys, JAK2 is seen in yes, 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 and no. Well, some students said that it was not CL. Sir, it was not CLL. It was basically a MDS. Some student told it was actually, sir, a CMPN. Well, whatever it was, remember, it is maximally seen in polycythemia vera. So the best answer, a single choice answer would be PCV, because 60-70% cases will show you JAK2 mutation. Remember, essential thrombocythemia will show you definitely JAK2 mutation, no doubt about it, but will also show you a mutation that is called as calretinine mutation. PMF will also show you JAK2, okay, JAK2 and the calreticulin or calreticulin mutation. Calreticulin or the calreticulin mutation. Okay, the answer is PCB here. Well, Rees Eckert alerting fluid is used for RBC pipette. Well, it is used for RBC pipette because this fluid is used for platelet studies. Okay, platelet studies. Now remember guys, the amount or the number of platelet is in actually lakhs and RBC is in millions. So one which is used for studying a platelet will also be used for studying a RBC. Well, these are the three types of platelets, which are the type of pipettes, which now you must know. See, a WC pipette has a marking of 11, 1 and 0.5. RBC has 101. Why? Because look at the counts guys. This is just 1000 and this may be 11,000. But this one would be 1 to 101, which means it will be 101 lakhs. Therefore, a number of 101 will be RBC pipette. And this can also be used for, yes, platelets. A hemoglobin has just a marker of 0.02 ml. Okay, this is how you will identify the three types of platelets, and Rees-Eckert fluid is used for platelets, can be used in a RBC pipette because RBC pipette is used also to count the platelets and the RBC. How it is done, where it is used, there is completely physiology, and you might have done this experiment in the first year of your physiological training program. The type of epithelium not found in, well, there's a marking given here, and this marking was pseudo-stratified columnar epithelium. Marking was showing you pseudo-stratified columnar epithelium. Well, this is the cilia and this is the pseudo-stratified columnar epithelium. Well, it is seen in oviduct, yes, epidermis, yes, bronchus, yes, but ependyma shows a simple squamous epithelium and at times lined by the stratified cuboidal epithelium. Cuboidal plus a simple squamous epithelium. Both of them makes a lining of the ependymal lining. So the answer is definitely A. Well, according to the immune surveillance, I had made this video and was called as immune checkpoint inhibitors. I told you over there about the PD and PDL1. I told you also about the CTLA4 antibodies, and I hope you have watched that videos in the Robbins 10th update. Basically, these are all the checkpoint inhibitors which does not allow a tumor cells to proliferate. So basically, if you are giving an antibody to the CTLA4 or giving an antibody to PD receptors, you're basically inhibiting the tumors. But see, binding of 28 also lead to immune tolerance. So the answer is B, because you all know that mutation of the tumor cellular genes has nothing to do with the antigen toxicity. About these two, I just revise you in short. So what I told you in my other video, if please watch the videos, the video is called as immune checkpoint inhibitors. It is recently updated video and you must all watch that. So I told you that there's an APC, and there is this antigen. Okay, there's a tumor cell here. So this tumor cell, it has the, or antigen, this basically has a T cell receptor. It is a T cell receptor, okay, and this APC, it has a HLA. Okay, let's consider this one to be a T cell. Okay, this one to be T cell. Now here there is a C28, okay, 28, and here there is a molecule called as PD1 and the CTLA4. Okay, this is actually the B71 and the B72. Now what happens, that sometimes what happens, there's a binding of this molecule so that 28 is not activated. If 28 is not activated, the T cell will not be able to destroy any antigen. Okay, similarly, if there is a binding of C28, then what will happen, the antigen is not destroyed and it's called as immune tolerance. So something, if binds here, see, understand, if something binds here and blocks this, the T cell is not able to destroy the antigen, and hence it will lead to immune tolerance. Also, I told you that the PD and the CTLA4, they cause the expression of this, they cause the expression or decreased expression of the B7 and B72, so the T cell is not able to destroy the antigen. Please watch that video again in the immune checkpoint inhibitors. Okay, the gross specimen of the bone tumor at lower end of femur shows 10-year-old child was seen. And please understand, some students was telling us that the image was this, Well, some student told that the image was something like this. There are different images. See how. In this image, you're seeing there's a growth is of basically the bones. The bones are actually growing here. These all are the bone growth. Now, if there's a bone growth, it becomes the bone forming tumor called as osteosarcoma. If this would have been lytic lesions, they would have a huge number of destruction of the bone like this, the destruction of bone like this, it would have become giant cell tumor. But now you see, if there is a image like this given, and what you're seeing is the smooth shiny cartilage. You see, if there would have been a smooth shiny cartilage shown here, a smooth shiny cartilage shown here, it becomes what? It becomes a chondrosarcoma. Okay, so you must be able to identify these images. Was well discussed in my vibe session also, that if there is a bone forming tumor, you would see there is bone here. See, there's a bone here. These are bones. But if there's a cartilage forming tumor like a chondrosarcoma, there will be shiny cartilage at some areas, and this becomes a cartilage forming tumor, chondrosarcoma. The image that I have been told is this one, and for this image the answer would definitely be a case of osteosarcoma. A bone marrow examination shows pancytopenia, which can be correct. Now this is a changed options with the option I actually got. Remember, megaloblastic anemia with hypocellular bone marrow. So remember one thing, a megaloblastic anemia will show you hypercellular bone marrow, but if it shows hypercellular bone marrow, it will surely show pancytopenia. Again repeat that megaloblastic anemia will show you hypercellular bone marrow, but definitely will show you pancytopenia. But if a megaloblastic anemia shows a hypocellular bone marrow, will surely again show a case of pancytopenia. Hairy cell leukemia with hypercellular bone marrow can show this, even though the hairy cell leukemia often shows hypercellular bone marrow, but if shows hypo, will show you a pancytopenia. MDS with hypocellular bone marrow will definitely show you a pancytopenia. APML and this myeloproliferative will not show anyhow a pancytopenia. So in this question, you have to look for this pancytopenia and look at this cause, this one, or this one. They can definitely show you a pancytopenia in this question. Okay. See, a 45-year-old lady with large breast, okay, mass, okay, and shows redness, tenderness, and a sudden rapid increase for last 15 days. Look at this acute history, guys. Such an acute history can be seen only and only in the inflammatory carcinoma breast. Remember, galactosile will not show you redness and will definitely not show you a tenderness for last 15 days. Giant fibroid adenoma, it's a benign tumor and will definitely not show you an increase in size for the last 15 days. Aerial hyperplasia, the same thing. This last 15 days is definitely telling you that it is an inflammatory carcinoma of the breast. Okay, so hereby I thank you for giving me all these wonderful questions and suggesting me the right options for this all questions. So my take on this entire thing is that, guys, everything is all about conceptual. Try not to include the right answer, try to exclude the right answers. Okay, now what you must do is, don't worry however your exam has gone, just make sure from today you just look into excluding the options and look at a case based scenario. If any of the question you found was not exactly the same with the altered options, put in the comment box below. I'll try to answer your questions right in the comments as we move ahead. Okay, so my own Telegram group channel link is also in the description below. Please do that and subscribe to my channel to keep updated with the more upcoming questions. And this is how you all will be asked in the recent NEET also going to happen. I wish you all the best. Take care, stay healthy and stay safe. Bye-bye.